The next presentation, Dr. Nikolov, what's next when everything else fails?
Thank you for the committee for having us here again in Sofia, in this perfect organization and learning curve for us. So today I will present a case, patient 55 years old, patient with a gangrene of the right foot, was referred to our clinic. Previously he was denied for bypass surgery by the vascular to hospital in vascular surgery. And when he came to our hospital, we tried endovascular procedure to try to revascularize the leg, but it was only attempt, we didn't succeed anything. And we referred to the orthopedics for high leg amputation, actually above the knee amputation. But the surgeons discussed with us, according to the angio, that there was no enough vascularization, it was poor collateral vascularization, and they asked for us to bring some blood to the thigh so they can achieve better outcome with the amputation. Last year, I think it was here in BEC, we saw the vascular arterialization of the tibial vein. In live case here, it was done, I think, last year it was. So I was thinking, I said, let's go tomorrow for revascularization, arterialization of the great saphen vein. I searched a bit and I saw that there is a lot of cases with the below the knee revascularization, arterialization of the tibial vein, and there is a deep vein arterialization, but we don't have that dedicated stent for diverting flow stent that was needed for this kind of intervention. So I said, because we're doing a lot of sclerosation of the veins, let's try to connect the superficial femoral artery with the great saphen vein. So this is the angio. You can appreciate the huge calcified, the whole aorta, the whole trunk, everything was calcified, heavy calcified, and there was no blood down to the foot. So this was the attempt day before, on 24th of March. We tried with the right brachial artery just to have a vision of the artery, then start with anterograde with a more support, but there was nothing crossing through this calcified lesion. So the next day, we decided to go for this great saphen vein arterialization. We make the first introducer in the distal part of the femoral artery of the great saphen vein. We, on the left picture, you can see we put the snare near the inguinal region. Then with the wire through the skin, through the great saphen vein, directly through the snare, we directed the needle to the superficial femoral artery. And on the right screen, you can see that we punctured the femoral artery, and glide wire 0.14 was guided to the iliac arteries, where was waiting the guiding catheter. So we make the arterial externalization of the wire through the brachial artery. And then we put guiding catheter so we can make puncture, bigger puncture of the calcified artery of the femoral superficial artery. We make the film that we are on the right place, make the predilatation with 40 by 200 balloon, and started with the graft stenting. That was actually, we make the externalization of the wire after it through the distal introducer of the great saphen vein. And we put the first graft stent from the femoral superficial to the into the out vascular space. Second graft stent from the to the great saphen vein. We try with the balloon to cut the valves, but we didn't succeed. So we used the supera stent to stent the great saphen vein. And finally, we received this result. That was, we were so happy that actually we put blood down to the foot of the patient. So after 5 days, the patient of the great saphen arterialization, the patient went in the surgical orthopedic room. It was below the knee amputation, and the words of the orthopedic was, it was a lot of bleedy amputation. That was very happy a moment for us, because we achieved to bring blood to the foot, actually, to the below the knee region. This kind of patient are patients that are living in villages, and they don't refer to medical assistance only in emergency. After 2 months, the same patient came with a gangrena on the left foot. According to the previous intervention that we done, we saw that the perforator veins were a much better option not to stent all the valves in the superficial vein system. So because we already did the ultrasound of the patient, there was a good perforator vein starting from the femoral to the crural part, and we decided to go directly to the perforator vein. So we did the angio of the previous intervention that was done 2 months ago, and you can appreciate the fully functioned arterialization of the saphena, and you can appreciate the perforators are now turned into the arterial phase. You can appreciate on the right side, there was again the same calcification with a very poor vascularization, collateralization system. So we did the same thing. We puncture two introducer, the distal femoral part. We puncture again the snare. We puncture the artery. Now we use destination guiding catheter so we can deliver the graft stent and predilatation of the common femoral and superficial femoral artery. These are the predilatation, and this is the final result after the arterialization of the perforator vein that we put introducer down to the foot. The thing was that after putting the introducer, after closing the introducer, there was no blood. So we did, I punctured another perforator that was connected to the small saphena arteria, vena parva, and we make this extracorporeal anastomosis just to provide enough blood so the patient will be prepared for the amputation. Fortunately, this extracorporeal bypass was lasting only for 12 hours, I think, and after everything was occluded, but the patient received below the knee quality amputation, and the result was quite good. We did the angio after the intervention. After 1 or 2 days, you can appreciate that there was again perforators around the knee segment of the left leg. And the main thing is all vascular surgeons, radiologists, interventional, or the cardiologists that are in this kind of mess, working with this kind of patient, we have to think outside of the box, because it's the only way that we can manage saving our patients. So if you choose a job that we like, we will never work another day in our life. Thank you for your attention.
Thank you very much. Any question from the audience? I have one. In my daily practice, I use valvulotomy. It's very easy, and you don't put a stent inside the saphenous vein. Yeah, I don't feel comfortable with a stent in the saphenous vein. The patency is lower.
Yeah, and, of course. Of course, of course. The main thing is that in our hospital, we are a public hospital, but we don't have vascular surgery. We have actually one young guy that's now on specialization, and he's our future in the vascular and endovascular surgery, and we don't have any devices that are needed for a valvulotomy. But we try with the balloon, with the wires in the balloon. It's like an endovascular procedure. You put it in the sheet, the valvulotomy. Yeah. It's very easy. But we don't have it as a device. So.
Okay. Thank you very much.
Thank you.
Nice presentation.
It's Professor Petrov.
Dear Chairman, thank you for the possibility to present our results with the artificial intelligence-assisted thermography. We mentioned several times that the peripheral arterial disease is one of the biggest challenges nowadays, because it is the bigger marker for cardiovascular disease. And this is the Times Square Kelvin Health presentation in Times Square. And these are my disclosures. I mentioned the peripheral arterial disease is definitely one of the biggest predictors for worse outcomes by cardiovascular point of view. And because of that, it's very important as a screening, population screening, to have a good, reliable method to detect peripheral arterial disease in the population in order to have timely diagnosis and timely treatment. And the screening for peripheral artery disease nowadays in the guideline, the golden standard in brackets is the ankle brachial index. But in fact, all we know that the ankle brachial index is not a precise method. So, for example, in diabetics medial calcinosis, the ankle brachial index is absolutely incorrect. And also in the at least half of the cases, the measurement of the ankle brachial index is not exact. And of course, we have the machine-assisted vascular examination like the duplex that is really the golden standard to show the extent of peripheral arterial disease, but not always such a device is available in, for example, in remote places. So we need, for early recognition of patients with peripheral arterial disease, to have a non-invasive and safe, without radiation and contrast, quick and reliable, and non-operator dependent, and possibly no physical contact method to show, in fact, this pathology. Hippocrates has left the testament that almost, let's say, more than 3,000 years ago, that should one part of the body be colder or hotter than the other, disease is present in that part. So this is the first supposition of Hippocrates, telling us that possibly the peripheral arterial disease can be recognized by temperature. And the first data about thermography utilization is coming from the astronomy, and it's a non-invasive diagnostic technique that measures the skin surface. It's based on the principle that the human body emits infrared radiation, and thermal asymmetry, difference left to right between corresponding body parts, is probably one of the biggest sign of pathology in this situation. I mentioned that the thermography started with utilization in astronomy, crossed through the military application, and landed in the medicine. And what about the medical application? In fact, using a very small but high-resolution FLIR camera, we are making a thermography pictures in several minutes without touching the patient body. And with the utilization of artificial intelligence algorithms and with our support, let's say, to teach the algorithm following the angiosome concept, what is the healthy zone and what is pathological zone. And based on investigation on 3 continents with colleagues from Argentina, UK, and US, we have gathering data. So up to date, we have more than 4,000 patients examined by this method with the thermography, and with excellent results, reaching very good sensitivity and specificity, validated by golden standard angiography, Doppler, and CT. In fact, the first publications about the role of thermography to detect not only the pathology, but also to show, like shown in this publication, to show the improvement of the supply after surgical or endovascular intervention is dating since 2017. And we have many scientific publications regarding this technology. And can you guess what is the underlying situation, pathological disease? Those of you who were thinking about Leriche syndrome, yes, you're right. This is a Leriche syndrome. It was obvious in this picture that there is a lack of perfusion of the lower legs. I will show you several cases. Critical limb ischemia of a patient with contralateral amputation, 75-year-old gentleman presenting in Rutherford 4, extreme right lower leg ischemia in the left amputated in the past. So the thermographic diagnostic have shown almost complete thermoperfusion and angiographic below the knee flow missing. So you are going to make, in fact, the comparison. You see almost complete missing of the flow on the lower leg, very well corresponding to the impressive thermographic image. Speaking about angiosome, this is a typical case showing the role of thermography exactly for detection of angiosome restoration of the flow. So in this situation, we succeeded to recanalize the SFA and to recanalize the posterior tibial, but the thermography has shown that, in fact, the anterotibial zone is not exactly well supplied. So after the optimal like shown here, after the optimal and excellent flow into anterotibial, you see how it corresponding very well matching the thermographic image with full restoration of the perfusion of this lower leg. What about cerebrovascular disease? This was in fact my idea several years ago when we started with showing very good results in peripheral artery disease. I had a proposition to start exploring the idea on level of brachiocephalic vessels. So this was the first very interesting case. You see significant stenosis of the internal right carotid artery and almost full occlusion of the external carotid artery. You can observe what is the lack of perfusion on the face and also lack of perfusion on the skull, corresponding to the internal and external carotid artery corresponding. So this is the final angiographic result for the internal and after ballooning of the external carotid artery, and this is the situation after the procedure. So restoration of the thermoperfusion both on the skull and the face. And this is before and after to make the comparison. The second case is even more dramatic. It was a young lady, 53 years old, after recent Lima graft to LAD with coronary artery disease. And during the rehabilitation in a relatively remote rehabilitation center, several days after the dehospitalization, they called us, our colleagues from the rehabilitation center called us that the lady has a stroke. And we asked them immediately to transport the lady back to our hospital with aspect score of 7 points and NIHSS score of 9 points. So immediately after coming to our hospital, we performed in several minutes the thermographic imaging, showing definitely the right hemisphere acute lack of perfusion. And what was the finding in the angio? It was corresponding to what we have expected. So there is a right middle cerebral artery occluded, most probably thromboembolization, because she had in the past several episodes of atrial fibrillation. And this is the reaching the clot with the aspiration catheter. After engaging the thromboaspiration catheter, this is the removal of the thrombi. It was it looked like, by palpation, it would look like not a very fresh thrombus. It was probably was in the left atrium, and during this expel from after the sinus rhythm was restored, went to the right middle cerebral artery. This is the result, the angiographic result after the thromboaspiration, full restoration of all the branches. And also on one more, several minutes later, and this is the result with the thermography. So it's a full equalization left to right and acute restoration of the thermoperfusion. And fortunately, she restored practically ad integrum, and she's doing very well now approximately 1 year after the procedure. As a take-home message, the AI-assisted infrared thermography carries numerous benefits. It's non-invasive, non-operator dependent, it's radiation-free, it's time-saving, it's detecting early changes both on peripheral and cerebrovascular disease, and there is a huge potential of early detection of hyperacute hypoperfusion phase of ischemic stroke, probably in the near future. And thank you very much for your kind attention.
Thank you very much for the wonderful presentation. Any questions from the floor? If not, may I ask, you have such a big learning curve with a lot of patients. The results are perfect, but I didn't understood. This is based on photos taken by a camera.
Thermographic, yes.
Yeah. So, is it adapted for regions in the world, because the skin color is different in all the regions?
In fact, we know...
Did the skin color has impact on the quality of the... No,
not at all. It's temperature. It's not
temperature.
Color. It's not color. In fact, the colors are coded temperature grades. So here, let's say yellow, red, green, and purple. But we can teach the software to be just the opposite. So it's matter of temperature, not matter of surface color of the skin. Yeah. And this is one. And the other thing, it's definitely operator non-dependent. All the other methods that we have discussed, ABI, duplex ultrasound, position of the transducer, obviously it's operator-dependent methods. In this situation, a nurse or even non-medical staff can take the picture, and the pictures are uploaded immediately in the part of a second into the cloud. And in the cloud, the artificial intelligence is, in fact, elaborating the final thermographic result based on the angiosome concept that, in fact, during our investigation and improvement of the technology, we have taught, in fact, the AI.
Thank you very much.
Thank you. Thank you so much. Before giving the floor to Haitham, sorry, Dr. Hamid, for the delay. Here we will speak about the role of atherectomia. Yes, this is very nice. And I would like to share with you a very pleasant piece of news. This pleasant piece of news that there is a dinner after 7 p.m. in the Regale restaurant. In fact, it's a bar restaurant on the floor, on the lobby floor. So we are going to be more than happy to see you during this final dinner. And thank you very much for your participation and attention. Thank you.